Hi, everyone, and welcome to a really special show. It is National P.A.D Awareness Day. What is P.A.D? If you've been coming and listening to this show every single episode, you probably know by now, but if not, P.A.D stands for Peripheral Artery Disease. It is a disease more prevalent and deadlier than breast cancer, colon cancer, and prostate cancer combined. It's poor circulation in mainly the legs. And during this broadcast, we are going to focus on how you can actually prevent PAD. And if you end up with PAD, as 1 in 5 people do over the age of 60, 1 in 10 over the age of 50, we're going to talk about how you can actually stall progression on your own with walking. Yes, walking is medicine, not just any walking, not just a leisurely jaunt. We're talking about walking as a workout, and we're going to get into details in just a few moments. But on this National PAD Awareness Day, I just want to take a moment and remember a very, very special person in our midst. It is Mike Matthews, our producer's mom, who ended up passing with PAD 3 years ago last night. And so we just want to take a moment to honor your mom, Mike, and we really appreciate you being here today and producing this very special show on National PAD Awareness Day. I'd also like to just take a moment to remember my mom, who lost her life today, 3 years ago, to an aortic aneurysm. And in both cases, driving home the importance of making sure that you chat with your doctor. Chat is an acronym. Every single annual appointment, I want you to chat. Have the doctor check your carotids. That's C. H, have them check your heart. A is for abdomen, for aneurysm, and T, of course, is for toes. Have them check your foot pulses, your leg pulses, and that is for peripheral artery disease. Very important to chat. A great reminder on this National PAD Awareness Day. And so with that, I want to introduce my amazing limb saver, Dr. John Phillips.
Hey. Happy Saturday. Sobering, right? Like, obviously, it's important to remember folks who have passed from various illnesses, and PAD is one of them. And Mike, thanks for producing this. And Kim, obviously, very sad what happened to your mom. But I think we cherish their memories, and I think we just kind of try to use that to further push the rock up the hill, so to speak, with respect to raising awareness for various medical issues. PAD is one of them. We talked about triple aneurysms, etc. So we're going to honor their memories, but we're also going to use them as inspiration to help others. And I think that's why we do this show, why you spend so much time, why you're writing a book on walking, which I'm really excited to learn more about. Because when I think of walking, I think of just putting one foot in front of the other and just moving forward and maybe backwards. But this will be a fun show. I'm interested.
Yeah, I mean, they think that walking, well, what's your big solution with walking? I've been doing that every day since I was a toddler, but hold on to your sneakers, because we're about to dive into why this everyday activity is actually a secret weapon against PAD. So big things to come. But first, I think we should get things started with a moment of inspiration.
Dr. John Phillips' spectacular vascular moment of inspiration.
Okay, so since we're talking about walking, does the name George Megan ring a bell?
No.
Probably not. Probably not. No. Okay.
I almost, if you gave me time, I was going to Google him.
Well, so evidently he is thought to have walked the longest distance ever between 1977 and 1983. So almost 2,500 days. He walked from Tierra del Fuego in South America to Prudhoe Bay, Alaska, which is over 19,000 miles. Okay. And so that's crazy in and of itself. And we'll get into why distance matters, not maybe 19,000 miles, but why distance matters when we talk about walking and exercise. But so one of his quotes, which I thought was just kind of funny, but I think it speaks to like relativism, right? So he's quoted as saying, if I were going uphill, I was relatively happy, since I would sooner or later be going downhill. Whereas if I was going downhill, I wasn't all that happy because I knew I would eventually have to go uphill. So, I mean, life is a hill, right? I mean, you're going up it or you're going down it, and you have to enjoy the ride. But I think it's on the way up to the mountain that sometimes means the most, as opposed to maybe going downhill. But I thought that was kind of a little bit of lighthearted, and a guy who walked 19,000 miles over 6 years. For what reason, I don't know, but clearly he is quite a walker.
So he probably did not have PAD, and he had lots of collateral vessels. So that's a really great segue into what we're going to be talking about over the next hour, which is our collateral nation, our collateral network of vessels. Why do we need to walk? When
Sure.
it comes to, of course, we know that walking, if we walk at a brisk pace, it has the cardiovascular benefits, right? It's great for your heart. It's also great because your calf muscle is like your second heart. And with every step you take, it's helping with the veins. It's helping that blood flow back to the heart because your muscle there in the calf is contracting and pushing that back. But what most people don't really know about are the collateral vessels that can develop when the arteries, you have your human superhighway, the arteries send blood flow south, the veins back north, but these arteries that send blood south can get all mucked up, just as in your heart, with lots of plaque, all the fats, the cholesterol, even clots, all of the above. But when you get blocked up, your body actually responds and says, whoa, we need some detours, right, Dr. John?
Yeah, so it's kind of interesting. Like in the heart, for example, people that survive a massive heart attack have often developed. So they'll have an underlying blockage that maybe it's like 50%, and when the heart attack occurs, it blocks 100%, and that's obviously a life-threatening issue. But as the progression from that 50 to 100 or whatever it is, some people have the ability in the heart to develop or have these collaterals that are kind of pre-existing, or they've started to kind of develop through a term called arteriogenesis that we'll get into, and that's a lifesaver for people, like literally. It's those folks that are running and just drop dead from a heart attack that don't have these collaterals. In the P.A.D. world, collaterals are huge in the sense that they're kind of like that bypass, nature's bypass, that way to offload that blockage and help people continue to keep the leg perfused, getting good blood flow, and then ultimately just adapt to that blockage and further, kind of allow them to walk or function at a pace that they may not have been able to do so prior to. But again, it's all about conditioning. It's conditioning the muscles and conditioning the arteries, so to speak.
Yeah, and so coming up right here on the Heart of Innovation, we're going to talk more about the physiological mechanism of collateral vessel formation. We're going to talk about just the very basics of the chronic reduced blood flow due to those blockages, the angiogenesis or the arteriogenesis process that Dr. John was mentioning. Also the stress, this shear stress stimulation that helps in this formation, the hypoxia induced factors. You don't want to miss what we got coming up, because we're going to really inspire you to walk. And we're also going to hear some patient stories. Some patients with PAD who started walking, they were inspired by a video that we shared with Dr. Oneida Dubois. And she really inspired some of these people to walk and grow their collateral vessels. And I guarantee you will too. So stay with us right here on KDOW. Don't go away.
You have leg cramps that stop you in your tracks. Aching and tightening that always comes back. It could be your arteries signaling something's wrong. Let's dive into this journey, come along. Walking down the street, feel the birds at in. Simple strolls turning into fights within. Don't ignore the signs, your body's playing loud. Time to act now, stand up and be proud. Peripheral artery disease is more than just an ache. It's your heart's message, don't let it take a break. Seek the help you need, your life's worth the fight. With awareness and care,
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Hi, everyone, and welcome back to a very special show on National P.A.D. Awareness Day, where we are talking about the best medicine. It's not surgery, it's not interventions, it's not a pill that you take, but it's something that you can do anytime, anywhere, and it is walking. You can walk to improve your circulation. And we're going to talk about the physiological mechanism of action by which collateral vessels are formed. These are your natural bypasses. These are your little lifesavers. They're your little limb savers as well, because your body has this collateral network of vessels that pretty much lays dormant. You can barely even see them with a CT scan with contrast dye, right, Dr. John? If the arteries are completely open, it's when the arteries start to narrow, and they're looking for, with every step you take, every movement you make, a way in which they can get that blood flow down to the tissues, the muscles, and your toes.
The way I understand it is that these vessels they exist, so they're already, they're already little branches from a main artery, and so it's kind of like looking at a big tree, which I'm staring at because they're barren, because it's 35 degrees here in Columbus and raining, and so the trees in my yard have no leaves on them, and I look at their branches, and it's kind of as though if you looked at, so the little arteries are the tiniest branches, kind of like way up, as towards the ceiling or the canopy, and what happens, or the way I would describe it, is that imagine a creek, and so you've got a creek where there's water kind of running throughout that creek, and it's at a certain clip. Well, if you threw a bunch of rocks in that creek, the water would divert itself somewhere, and it would probably find a tiny little crevice in the ground, and then that crevice would kind of break open with the pressure from the water, and it would get bigger, and then the water would reroute itself, and that's kind of what the collaterals do. It's recruiting known pre-existing blood vessels that weren't seeing a pressure gradient and therefore not really perfusing much, but they're there and they're laying dormant, and there's a process of several steps that occur through this creation that then allows these vessels to kind of plump up, so to speak, and then take over. They're not, again, it's getting from point A to point B is a straight line for the most part, and so you're taking multiple turns basically, so it's not the best route, but it is a route, and that's why people will look at you and be like, well, your artery's blocked 100% in the thigh, but you've already, rerouted things. And they're like, that doesn't make any sense to me. And that's how I explain it to them. The beauty of the way we're built is these collaterals.
Yep. And so what is that formal name for this process? Is it, you call it arteriogenesis or angiogenesis, in terms of the ways in which these blood vessels actually dilate? And as you're saying, they grow like tree roots. And I've talked to a couple of vascular surgeons who hate when I say that they grow. But how else do you describe how they're able to end up, building out and literally, attaching themselves or reattaching themselves back into a vessel just below where the blockage is in the artery?
Well, again, it's I call it recruiting. So they're kind of laying dormant. They're actually, they're getting blood flow to some degree. But when you change, again, in that stream, you block the flow with a big rock, and then the water branches out, and then it kind of starts to create a divot in the ground, and then it allows more water to flow. That's kind of, those divots are there, those little arteries are there, and it's a function of, so for example, I did an angiogram on a patient who had all three. So in the leg, not to get too far into the weeds here, but in the leg, the artery is pretty much a tube until it gets behind the knee, and then it branches off into three other smaller arteries that then get into the foot and create a little loop. So this gentleman had all three of those arteries blocked, but they'd been blocked for so long, he had created such this dense collateral network where instead of a straight line, you're seeing like squiggles. It's like a little kid, drawing a crayon. I mean, just squiggles everywhere. But these little arteries are just, boom, they're getting blood flow, and they're providing tissue nutrients. And it's through So the mechanism of arteriogenesis or angiogenesis, you create something called shear stress within these little tiny vessels. So the vessel wall gets shear stress to it. So maybe think of it as kind of being stretched a little bit, and that in and of itself activates the cells. They're called the endothelial cells, and they start to express properties to release growth factors and things of that nature to then cause that cell, the cell gets bigger, the artery gets bigger, it remodels, there's inflammation that occurs. Again, you're just recruiting all these members of an army, so to speak, to kind of help get that vessel bigger and ultimately do what it's supposed to do, which is deliver oxygen and nutrients and things of that to the muscle and the tissue.
And part of the process, the stimulation is about oxygen deprivation and getting your body to a point. The stress kind of triggers the collateral vessels, but also that stress on your muscles can actually teach your muscles to do more with less. And that's part of like pushing through, right? Pushing through, trying to take one more step. And it creates this oxygen deprivation in the muscles that helps them to adapt. Is that correct?
Right. That's the term that I would probably use is ischemic. So ischemia is lack of oxygen, lack of blood flow, ischemic preconditioning. So the body, so the heart, for example, is a muscle, right? And the theory that people can do okay with multiple blockages in their heart arteries is because the heart itself gets preconditioned to this lack of perfusion and blood flow, which was reduced oxygen, things like that, and nutrients. The heart adapts, and the muscles in the thighs and in the calves and in the arms, if there's blockages up there, they can adapt to it. And I mean, people, again, with lots of blockages, they're not running marathons, and neither are folks that have, in the heart, they're not running marathons, and neither are folks that have significant P.A.D. for the most part in their legs, but they're adapting to it, and they're able to continue to have pretty good quality of life if they walk appropriately, which I assume we're going to get into at some point here.
Yeah, I think it's about time we talk about that elephant in the room, or should I say that ache in your legs. That's right. The C word, claudication, right? I know what you're thinking, though. Finally, we're going to talk about how to make this pain go away through all these collateral vessels. If I have all these collateral vessels, then why do I have the pain? Well, hold on to your socks, because we're about to flip the script on how you actually view this discomfort, I think. But first things first, Dr. John, I think we need to break down what claudication actually is. And this, I don't know if you know, but the word actually comes from the Latin claudicare, which means to limp. It's that ache, cramping, or pain you feel in your legs when you walk, of course. So for many people with P.A.D., it's like having a little personal rain cloud that is following you around and raining on your walking parade.
Yeah, I mean, the term, I call it angina of the legs, or whatever the extremity is. But basically it's described as cramping, aching, heaviness, tiredness with exertion. And that's really the key differentiator. And we have ways, I know we've only got like a minute or so left, but we've got ways to differentiate true claudication with what's called pseudoclaudication. Well, the symptoms are similar, but it's not from a plumbing issue, so to speak. But yeah, claudication, it's there, and it's something that we really hone in on with respect to a symptom for P.A.D., and we talk about how to improve their claudication through various mechanisms, one of which is walking.
Yep, exactly. And so coming up right here on the Heart of Innovation, we're going to talk more about this pain that you experience when you walk, called claudication. And I promise you will no longer look at it as the enemy. It might just become your new best friend in the fight against P.A.D. And I know that sounds crazy, but stick with us right here on the Heart of Innovation, right here on KDOW, because we're about to uncover a secret superpower hidden in your discomfort. So stay with us.
Your type of condition is called critical limb ischemia. It's the most advanced form of PAD or peripheral arterial disease.
Every 4 minutes, there is an amputation in this country due to PAD and diabetes. We also know that 85% of these amputations are preventable with early intervention.
It's a flip of the coin. Patient prognosis is tied to whether or not they are referred to a true expert in the management of peripheral arterial disease.
Do you know if your physician is an experienced CLI operator?
When you're in the hospital dealing with doctors and stuff, you figure they know what they're talking about.
The skill level varies doctor from doctor and hospital to hospital.
Patients with limb threat are in constant fear. The depression that someone experiences after they lose a limb is equivalent to those of losing their spouse of 40 years.
I was stuck in a wheelchair close to 2 years and my husband had quit work.
I didn't know what to do at this point because we had nothing but infections and hospital stays, infections and hospital stays.
And they took one toe, another toe, and then it was another toe, and then half his foot before he was even diagnosed with PAD.
And all I heard was, "What are we doing here? Just cut it off." And I pulled the curtain back like, "Are you kidding me?
Do you really want to go through all that?"
That's crazy. That's insane.
The protocol is to send them to amputation. Always, always, always get multiple opinions.
We do have options.
We need to listen more to our patients.
If you're going to chop off their leg anyway, why not just let someone else try?
This is the progression. First comes the wounds, and then comes an amputation. And I wasn't going to accept that.
So that's what it's like to try to save a leg.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Tim, I was trying to think of something clever to say about walking and, the tightrope, whatever. It just couldn't. It didn't come to fruition here. So I will tell you that I think we should spend a little bit of time talking about deliberate walking. And during the break, you mentioned something about steps that I'd like you to kind of highlight for us, because I will say a lot of my patients tell me that they're active at work and it's kind of start stop and they got their 10,000 steps in, and for me it's counseling. Like, that's great, but that's not really the exercise that I need. But it sounds like you have some data or have read that the number of steps, if you're not doing it deliberately and exerting yourself and for a period of time, don't really even matter, right?
Yeah, I mean, we hear it all the time. I got in 10,000 steps today. I got 15,000. I got 20,000 steps this week. And don't get me wrong. I mean, that's fantastic. Regular movement throughout the day, of course, it's really crucial for your overall health. However, when it comes to actually improving claudication and growing these vital collateral vessels, these accumulated steps throughout the day may not be as effective as you think. Research supports the approach that you do need intensity when you're actually walking in order to improve your claudication. There was a study in the Journal of Clinical Medicine that found that adherence to a structured, supervised exercise therapy program was more effective in improving claudication symptoms compared to just general advice to just increase the daily step count. And then there was another study that I read the other night that was focused on home-based exercise programs for PAD, and it emphasized the importance of exercise intensity once again. It's called the LIGHT study. And it found that low-intensity walking programs, which did not induce ischemic leg symptoms, you mentioned that earlier, were significantly less effective than high-intensity programs that really push the patients to the point of claudication. And we're not just talking about mild claudication or moderate claudication. We're talking about on a scale of 1 to 10, you're walking and that pain gets to the point where you think you're about to limp, right? That is the point. We're talking about a level 7 or 8 on the scale. You need to push through that mild claudication, that moderate claudication to get to that point where you are treating your walking like a workout. Let's say I can come up with an analogy here. Let's say you're over at the gym, right? And you're with a trainer and you're on that third set of bicep curls, right? And you're going, oh, I got 3 more to go. You know what? I can't do anymore. I can't do anymore. And your trainer said, just give me one more. And it hurts, right? It burns. You just think your arm is just going to break off if you just move it one more. And yet you do it. Your veins are bulging, but deep down, that's where the magic is occurring when you just take that one more arm up, that one more bicep curl. It's the same thing when you are walking. You have to treat your walking as a workout in order to improve your claudication and improve your symptoms. I don't know if that makes sense.
No, again, you have to push yourself to where it hurts and then just go a little bit further. And I don't have any hard data to support this, but what I tell my patients is keep an eye on with your Apple Watch or whatever it is, like keep an eye on how far you walk till you get the symptoms and then walk a little bit further. I mean, we don't want you to, you're not going to, again, I don't have P.A.D. thankfully, but you're not going to hurt yourself unless if you walk to the point where you can't feel your toes or your foot and you could cause some trauma that you don't want to have. But you're not going to, your calf muscle is not going to necrose or just not function properly. It's going to burn, but it's kind of like how TikTok or something is, you're just like scrolling and it's like, okay, only one more. Like maybe just do a couple of those and then you got to stop. You do have to stop. You have to get off TikTok at some point and you have to stop walking, but you've got to keep pushing yourself. And I tell my patients, keep track of it. And I think you guys have an awesome walking app that they can use, but you have to keep track of it because that in and of itself, we could talk about these dopamine hits in the brain, and like the dopamine's a very powerful neurotransmitter. It gives you like this sense of euphoria and things, and those are positive reinforcers, and you feel good about what you've done. So then you want to go do it again and do it again and do it again, and it becomes addictive. Honestly, it's like brushing your teeth or doing some type of habit that you do every day. Exercise needs to be an addictive habit.
Yeah, and it really is about your mindset to push through that pain. And it's been a game changer for so many patients. When I say really think about it, when you're in the gym and you're lifting weights and you're doing those bicep curls, you're doing those leg lifts or leg presses, you push the limits, right? You expect the pain. You expect to push through the pain. And if you take that mindset out to when you walk, you could literally push through that pain and be so successful. And we've had so many success stories, but the key is you want to start slowly. Begin your walk at a comfortable pace and give your body a chance to warm up. Don't just jump right in there. Okay. And then once you start cruising to that discomfort, keep walking until you feel that familiar ache or pain. And this is your body saying, okay, we're in that growth zone now. Here we go. But instead of stopping, just keep going. Aim for that level 7 or 8 on a scale of 1 to 10, or a level 3 to 4 on a scale of 1 to 5, right? It should be uncomfortable, but not unbearable. And you're really revving things up at that point. Now, if the pain gets that severe at a level 7 or 8, or a level 3 to 4 on a scale of 1 to 5, then just take a brief rest, just to the point where you think, you're doing okay. You don't have to get rid of all the pain, but just get rid of most of the pain to the point where you can start walking again. And as Dr. John said, it's not about the steps you take. It's about tracking the moment you start feeling that pain, and until that pain gets so bad it forces you to stop. That's what we call claudication time. That is so important. That is probably the most important thing that you're going to measure, because it's between those two moments, the onset of pain and that point in which that pain forces you to stop. That's where you're doing the work. That's where you're maximizing the collateral vessel growth. So on our app in particular, if you go to padhelp.org, you can navigate to where you can sign up for our app, which helps you to measure your claudication time. But secondarily is you want to measure that time from the moment you start to the moment you rest. And those two times should literally improve over the course of time. It's not going to improve day to day, but it's going to improve week to week. And Dr. John, by 6 to 8 weeks, I think that that you're going to really start to see that improvement. And that's where, if you actually did a CT scan with contrast, you'll start to see that collateral development, right?
Yeah, I mean, we see you can see the larger vessels, but to your point, this is a commitment, and you have to be all in to get to that. I mean, there's this notion of, some people stop developing whatever habit it is. They might stop it because they plateau. There's like this latency period, but it's kind of like water boils or freezes at 32 degrees, right? It doesn't freeze at 33. For whatever it is, it's got to get to 32. So you've got to get to 32. And we talk about PRs in weightlifting or whatever, like personal record. So get a PR in that time frame of walking when you get the claudication to when the pain becomes unbearable. And I do also say too, like when we talk about pain scales 0 to 10, I say 1 is very, very minimal pain, and 10 is a hippopotamus eating your intestines. So that is a really significant amount of pain. So I always kind of grade it that way, because a lot of people are like, oh, that was 10 out of 10. I'm like, no, that's not a hippo eating your intestines. That's maybe like a 6. I don't know why I picked a hippo.
And on that note, coming up right here on the Heart of Innovation, we're going to get to some questions. We have quite the studio audience here. We might even get a couple patient success stories. How walking is the best medicine and has changed the game for so many. So stay with us right here on KDOW. Don't go away.
You have leg cramps that stop you in your tracks, aching and tightening that always comes back. It could be your artery signaling something's wrong. Let's dive into this journey, come along. Walking down the street, feel the birds that in. Simple strolls turning into fights within. Don't ignore the signs, your body's playing loud. Time to act now, stand up and be proud. Peripheral artery disease is more than just an ache. It's your heart's message, don't let it take a break. Seek the help you need, your life's worth the fight. With awareness and care, we'll make it right.
Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Well, I think folks have heard enough of me talk. Probably not Kim, but nonetheless, let's get to our studio audience, because we got a lot of folks out there, and I imagine there's some interesting questions that we might be able to help answer.
And we did have a couple come in actually during the break. One was from Carrie, where she says, okay, so you really have to walk through the pain. And then Julie has followed up saying, hey, we shouldn't stop, right? We got to keep walking through that pain, because that's when we maximize the collateral vessel growth. And I want to give her some props, because she also mentioned that she started feeling some real pain at 1,000 steps, and she was able to push through to 2,500. And that is amazing. You have to start where you are. And I know that there are walking programs that are out there that actually say, okay, you got to actually get 30 minutes of walking in right away. So if it takes you 90 minutes, if it takes you more time to actually get those 30 minutes of walking in during that session, then that's what you got to do. And I say, whoa. That's a little overwhelming, because you have a lot of people that are being diagnosed at later stages, and they can barely even walk 5 minutes. So to tell someone that they need to sit there and devote 90 minutes of their day to try and get 30 minutes of walking in that time, it's just not realistic. So the way that we look at it is start slow. Ultimately, your goal is to build up to 30 minutes. If you can already do 30 minutes, try walking at a faster pace, a more brisk pace during those 30 minutes. And then if you can do that, go to 45 and then to 60, at least 3 times a week. But again, start slow, okay? Set your timer for 30 minutes and try to get in as many steps, as much walking as you can in those 30 minutes at a brisk pace. I don't care how many times you stop, especially in the beginning, but over time, I promise you it's going to get better. And I want to bring in Becky, because she is going to attest to the fact that over time, it does get better. Right, Becky? You can go ahead and unmute.
Yes, ma'am.
So you saw a video by Dr. Anita Dua, who is an expert in walking. She's a vascular surgeon out of Mass General in Boston, Massachusetts, actually where you are right now. and tell us about what was going on and going through your mind and the symptoms you were experiencing before you watched that video and what happened after.
I thought y'all were crazy.
Why?
I thought y'all
Why
lost your
crazy?
mind. There's no way you're supposed to put yourself through that pain, and it's an awful pain. Your mind tells you there's just stop because I'm gonna hurt myself. You know, that's what you think.
Yeah, and then what happened once you started? Did you have to do a lot with your mind to get yourself in the right mindset in order to go out there that first time and push through?
I did. I was actually laying in the bed smoking a cigarette, watching the video with you and Dr. Dua and the other doctors. And when I seen her face, how she said that it's not a matter of when or if you will lose your limbs if you keep smoking. It's only a question of when, and that you have to walk. And she explained the bucket, and that's where I was. I was in the bucket. I was past the bucket. I was going in the grave, and she made it better. So I spit out my cigarette that day. I got up. I went to the beach, and I could only penguin walk at that time. So I could get maybe 20 steps penguin walking. Oh. And I'd just go and I'd scream and cry and walk it out. And then it just got better and better and better and better. 30 days. I went at it every day for 30 days straight. And that's when I told myself, if it doesn't get better, I'll go ahead and file for disability.
And you're working now. You're back working full time.
3 years later now.
That's incredible. Was it about goal setting that really got you to stick with it day after day? I mean, you're a young woman, and that you were having trouble walking. I mean, that had to have been mortifying for you.
It was like death was right there. That's how you feel when your abdominal aorta blocks up 100% in both your iliacs. You feel like death is there.
Well, congratulations on all of your success, and now you're back working full time, and you're walking.
I don't want anybody to get confused. There's pain every day. There's pain every day. That's for sure.
But I think Becky, you gotta push it. It sounds like you had a goal. You set a goal, or at least a time frame, right? And you kept pushing towards that goal. I think it's important we talk about having habits of good, successful people have certain habits. One of them is like begin with the end in mind. So figure out what your end is and then reverse engineer to get there and create goals. It's important to create goals. We talk about with tobacco cessation, patients need to set a quit date. I'm going to quit February 23rd or whatever it is. And so you work up to that. You have to work up to a goal. Everything in life is working up towards a goal. And like Negan said, you got to climb the hill, and then you get to go down the hill, but then you're going to climb another hill. I mean, like, that's just the way life is. This is a race. We don't win, but you got to keep, no pun intended, you've got to keep at the race. Or maybe there was a pun intended.
And we're getting a question in here from Kay on LinkedIn talking about what happens when all of your main arteries below the knee are completely blocked. Can your legs survive on these collateral vessels, and what does it take? I would imagine that's a pretty painful process to continue to push to maintain your legs and not get an amputation just with collateral vessels on their own. But you've had patients. We also have Kevin Morgan, who's a PhD, former retired veterinarian, and also P.A.D. warrior and world triathlete who has complete blockages in his legs. And he is surviving on all collaterals and just pushes it. It's almost like walking becomes your full-time job to keep your legs if you want to keep them. But it's possible.
It is possible. And I think we need to focus on this as well, like the prevention aspect of it. You said it earlier. It's really hard to ask somebody who's in their maybe mid 70s or late 60s who probably has lived a sedentary life to get up and walk 30 minutes a day. We've got to get people in their 20s and 30s to be exercising regularly And I firmly believe, at least from a cardiovascular standpoint, the more physically fit you are when you do get hit with some type of ailment, because we all will, that the physical fitness and to whatever degree you are physically fit will determine how you recover and if you survive. People who are physically fit die of less cancer, they die of less cardiovascular disease. So yes, people with all three arteries blocked below the knee can't survive. I see it all the time, just because they're probably less active anyway when they get that, because it's a kind of a P.A.D. is a progressive disease. But we've really got to spend time on folks in their 20s, 30s, 40s exercising regularly so they don't get to that. And if they do get to it, they can still function at a high rate, have a good health span, as we talk about, as opposed to lifespan.
And you bring up such a good point, because Science Direct in the past year came out with a study that showed that they've seen an increase in the number of 18 to 27-year-olds that are presenting in emergency rooms in critical limb ischemia, the most advanced stage of PAD, on deck for amputation because of the diabetes epidemic, the vaping epidemic, a lot of those cigarettes, flavored cigarettes, focusing on and targeting our youth. So we really have to start not looking at PAD as an old person's disease, that it is something that's affecting everyone at a younger age. And we've got to focus on that prevention, focus on the lifestyle modifications, quitting smoking, getting your diet in order, but most importantly, walk. And coming up, we're going to have our final thoughts on walking as medicine. So don't go away.
Right now, my wife and I are in Disney. We come here every year for vacation for about 3 or 4 weeks. So let me tell you a little story. 2 years ago, when I had a bypass operation in my right leg and in my groin, and the one on my right leg below the knee to above the knee did not work. And when my wife was in a waiting room, talked to the surgeon after the surgery, she said, he was telling her about the operation, and she said, "What's next?" He said, "The amputation of my right leg." When I went to bed at night, I almost cried myself to sleep because I was going to lose a leg. And now things are a little different. Last year when we came to Disney, I was walking about 100 to 200 feet in a wheelchair 80 to 90% of the time. I'm sorry, 2 years ago that was. When I got back after vacation, I ran into UChem, or your website, and I started the walking program. Well, today is our 5th day here, and we averaged between a low of 6 to a high of 10 miles each day. And the other thing we're doing, we're staying on the 5th floor, and naturally there's elevators, but twice a day my wife and I are taking the steps, walking up the steps. And I can feel that. I mean, it kicks my ass, but excuse me, but we can make it. But I'm not saying it was painless, but it was bearable. It's unbelievable. Just the progress we made. And sometimes I get some pains worse than others. I think, maybe I'll try to go in and clear some of this out, but I don't think it's necessary yet.
Thank you so much, Sid, for sharing your story.
Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Hi, everyone. Welcome to the show. We are wrapping up our final thoughts here, walking as medicine, driving home this really important point on National PAD Awareness Day. And we have Marjorie that came in with a question here in our live studio audience. If I have to stop walking for a time for illness or something like that, possibly a procedure, do you start from at square one all over again, or are the collateral vessels permanent? If you don't use them, you lose them. We hear as people age, these collateral vessels start diminishing. What do you know about that, Dr. Phillips?
I don't know that they diminish. My hunch would be is that, because they're kind of recruited. So in theory, if they're not being used, they're dormant. But what I can tell you is that deconditioning is what the biggest issue is. And so it's estimated that for every day you're hospitalized, you lose 1 to 2% of your muscle mass. So that adds up over time. So you have to stay as conditioned as possible, which is why we preach the preconditioning, meaning exercise when you're healthy. But also you have to have good nutrition. So it's important to be eating foods high in protein to keep that muscle mass. And again, so fix what you can fix. Your diet, make sure your blood sugar's under control, things of that nature. Because we all will be hit with an illness of some sort, and that's going to knock us back a little bit. But if you're prepared, aerobically and from a muscle mass standpoint, then you can weather the storm better. The collaterals are always going to be there. It's the muscles, I think, that decondition and cause the issue for a lot of folks.
And Marianne is asking about weight training, and it does help. It all helps to strengthen your legs, but walking still is the best medicine, and anything you can do to complement that is definitely helpful. And doing those leg lifts, especially you can improve circulation by just going up on your tippy toes and back down to your heels, up on your tippy toes, down to your heels. You can also use, if you're sitting for a long period of time, it's not a replacement for walking, but you can use one of those foot cycles. And if you're in bed for a very long period of time due to recovery from a specific illness or procedure, don't forget about your heart. 3 in 5 people who suffer a heart attack have P.A.D. And even if you're not walking, you need to get that hand cycle and you need to just pump it. You need to pump it and get that cardiovascular system going. It is absolutely important. I am going to go to Douglas because I thought that was a really important question that Marjorie had. And there's something that Douglas, when he was in the hospital, many months ago, he shared a video of what you can do while you're in the hospital bed. The key is, number one, make sure you do have the circulation socks that are placed on you, right? But number 2 is, if you can do the foot alphabet, draw the alphabet with your feet, use your ankles, draw, numbers 1, 2, 3, 4, 5, all the way to 20, go to 100 if you can. Number 3 is ask the staff for a towel and just move the towel, lay in bed and move the towel forward and back and forward and back, which brings me to what Douglas was doing. Douglas, share with us what you did while you were in the hospital.
I still have it. I still do it today. I use paper plates from Dollar General store and put them on the floor. And if it's raining here, I put my paper plates on the floor and I move my feet back and forth. It's just exercise. And it's different than the bicycle because for me, I understand that I am actually doing the movement. I'm doing the movement forwards and backwards. If I'm on a stationary bike, it's kind of doing the work for me in part, and I don't need that. I need to move every muscle in my leg.
I mean, just doing something, some movement activity. We talk about folks moving their legs when they're on an airplane, right? Because that's from a vein side of things, but any movement activity is good. Any movement activity that occurs for a duration of time that's constant is good. We have a sedentary culture to some degree, and we just need to break that habit. So any movement activity is good.
Dr. Phillips, I think I asked him this, I brought this up yesterday, is every time, if I'm walking like that, every time I come to a stop, I have to start over, don't I? That claudiation time starts over every time I come to a stop. Is that how?
Well, again, the way I look at it is you've got your garden hose, right? And you're trying to, water the flowers that you get right when spring hits and they die within like a week, right? Because I'm a terrible green thumb. But you got to water them, and if you kink that hose, there's enough water that comes out to that's enough water for a little flower. But if you got a bush that you just planted and you got a kinked hose, that's not enough. And that's the difference between being at rest or light walking versus exercise. The hose is kinked. There's enough blood flow in the kink at rest, but not enough with exercise because the muscles need more because their energy requirements are more.
That's why with our app, it's really important. We only really measure when we're measuring the claudication time. We do ask that you just get in the habit of pressing that button pain every single time you start feeling the pain, just to be in the habit of doing it, because we look at it as, consciously acknowledging it, consciously acknowledging, it's like conscious walking. You acknowledge the pain and you're deliberately pushing through it as you would when you're doing that workout in the gym. And so consciously pressing that button that says pain puts it in your brain. It's like, okay, now the process begins. Now I'm going to start literally maximizing those flow. Thank you so much, universe, for this pain right now and for this natural process by which my body is now triggering its collateral network of vessels and forming those amazing natural bypasses and acting like tree roots in search of water to reroute blood flow around those blockages. But we only, if you're on our dashboard, we only measure the first one. We only actually log the first one that you do, because it's pretty consistent throughout your walk. And we want to get you actually having the onset of pain later. And then we want to get you to the point where that rest stop that you have to take is also later. So let's say your claudication comes on when you first start this process. Almost right away, you hit the button pain, and maybe at 2 minutes, you're like, this really sucks. I think I'm going to fall. I'm grinding my teeth. Yeah, don't get to that point. You need to stop, right? Stop and rest. Don't be discouraged. Hang out, sit for a few moments, listen to your favorite song, whatever it might be, observe a bird flying by, or watch something on the TV, right? If you're doing it in your house. And then start going again. The moment you start feeling that pain, even if it's right away, press that button again and go, go, go. I'll guarantee you by the second week, if you're doing this every day for a week, even just 5 days a week, the next week when you start doing it, your claudication time, it's not going to be the onset at 30 seconds. It might be the onset coming on at 45 seconds or a minute, and you're able to push it for literally an extra few minutes. Even if it's just an extra 30 seconds, it doesn't matter. You're starting to improve. You don't compare yourself to other people. That's really important. Everyone gets diagnosed at different levels. Everyone has different risk factors that are leading to and can affect where they're at, in terms of their stage of PAD. You focus on you, and the whole goal is improving. You may never run a marathon. That's fine. But the whole goal is to be able to live out your daily life and not have pain when you go to the grocery store or play with the kids or the grandkids. We had Dr. John Sid, who was on just a few weeks ago, who shared with us that 2 years ago, he couldn't even walk 500 feet at Disney World. And this year, 2 years later, after starting where the doctor had told him amputation was his only option, 2 years ago, he started our walking program, and 2 years later, he was walking 5 miles at Disney without any pain. That's awesome. Really what you want. And that's the power of walking as medicine.
I mean, we talk about food as medicine, walking as medicine. We need to be better in our society of preventing this disease. And if you prevent it, then you can avoid a lot of these complications from it. But set a goal. That's what I would tell you. Set a goal that's attainable and thoughtful. Write it down and hold yourself accountable to it, and you'll get there. But I tell you, the 6 inches between your ears is a very powerful organ, the most powerful organ we have. So you got to leverage that as well.
And Marianne is asking, is the pain only calf pain? Can it be at the bottom of the foot? It can be calf pain, it could be foot pain, it could be thigh pain, it could be buttocks pain, right, Dr. John?
Yeah, I mean, so if you look at your body, where the pain occurs at one level higher than where the blockage is. Okay, so if, these are my legs, all right, so here's my knee. So if you've got blockage kind of down here, oftentimes you get pain up in here in the thighs. And it's the same thing. If you've got blockage in the aorta, which is the big vessel, or the first two branches, the iliacs, those symptoms occur in the back, the buttocks area. Oftentimes, the blockage it's telling you where it is, right? So And that's how we can kind of localize it.
And you were mentioning, I think it was even just last week or the week before, that if you see someone that has a narrowing in their iliac vessels, that you would rather go ahead and go and treat that because they're less likely to grow collateral vessels in that particular region from aorta to iliacs, to a point, if it's significant narrowing, where it would relieve symptoms. So you like to go in and try and just give a little bit more flow.
Yeah, there's a couple of reasons. It's a huge vessel, and the durability of that procedure is very good, and those stents stay open for really, really long. I've got patients that have had stents for 10 years and they're open. It's different. It has to do with flow characteristics and things that matter, wall tension or whatever. But those people with iliac blockages, I mean, they love you after you fix them because they get their life back. Because imagine that buttock back pain that you get that just is really, it's often misdiagnosed. We've talked about this before, like making sure your doctor is assessing your pulses, because I've had numerous patients who have had back surgeries and stuff when in fact it's not their back, it's arterial issues. But yeah, those people just really, really do well if they've got a blockage there and we're able to open it up.
How about for some of those people, so many of our patients, Dr. John, and one of the questions that came in was about the fact that so many have back pain, back issues, sciatica pain, and that makes it really tough to walk. And that's where we have a physical therapist that came on, and he usually comes on Wednesday mornings at 8 a.m. Pacific time, 11 a.m. Eastern, to answer questions on our YouTube channel, youtube.com/at the way to my heart. And that's Dr. Chris Seenan. He's a doctor of physical therapy or physiotherapy. And he is saying that, you know, especially for those people with back issues, that it can be a little bit harder, especially for the uphill. So make sure that you maintain a flat surface if you do have those issues, number one. Number two is get a referral to a physical therapy department to start working on those stretches, to work on traction, to work on strengthening your lower back and building those muscles around there, so that when you are walking, it's not going to cause you as much pain and suffering, and you're going to be able to walk further to improve your PAD. But that's what he said. I'm curious from your perspective. I'm sure you have patients that have come to you and said, I can't do it because my back is, you know, I have so many issues with my back, so I can't walk.
Yeah, again, I think first and foremost, you try to differentiate between what's causing the issue with the patient. Is there some musculoskeletal problem, spine problem, or is it actually PAD? We have ways of differentiating that through testing, but some folks have both, and you know that makes it a little bit more tricky. But again, I think weight loss too. A lot of folks, you know, they're saying in 2050, like 50% of all Americans will be obese. So you get 360 million people. I don't know how many adults, whatever that is. That's staggering and scary. And so our bodies are not meant to have, you know, as guys, we get our obesity in our abdomen, and that's a lot of stress on the spine. And like that's, our bodies aren't meant to hold that much weight. So again, I keep harping on prevention, but that's really where this narrative should take us. And it's never too late for anybody to lose some weight, you know, to get healthier. But yeah, to answer your question, I don't know, I was long-winded, but I mean, yeah, if your back is really that bad, then you've got to look for other. I tell people in the sauna, or like, I'm sorry, in the pool. So swimming is good if you can do that. It's hard. A lot of people don't have access to pools, particularly in the wintertime, but that's probably a good alternative. And biking too, for some reason. I'll tell people say I can get on a stationary bike. It doesn't hurt as much. So do that. I mean, figure out, Mother Nature's pretty smart. She'll tell you when you can do something or when you shouldn't do something. Listen to your body. But also know that pain is there for, you know, pain is kind of good to some degree because it tells you that, all right, you're doing enough where it's making a difference, but it also is enough to tell you to stop.
But you need to know when, well, all exercise is fantastic, whether it's swimming or water walking or cycling or even rebounding. I've heard people improve some of their circulation doing that. You are not going to improve your daily walking claudication by doing those other things necessarily. In order to improve that claudication, And to really maximize that collateral vessel growth, you've got to do some sort of exercise in which you are pushing through that pain. You're pushing through that claudication, and that's what's key. And some people, and I'm going to put you on the spot, just two more really quick for you, Dr. John.
Sure.
Number one, well, there are patients that have diabetes, they can't feel that claudication. And they're walking, and then they're like, I can't feel anything. Am I still growing these collateral vessels?
A lot of the folks that I treat or see that have peripheral neuropathy, that's the term we use. It's typically in the feet themselves, not necessarily in the calves as much. So you have to be cautious, right? Because you do not want, that's why you go to a podiatrist, right? If you have diabetes and peripheral neuropathy, you go to a podiatrist regularly, have them trim your toenails, have them do a foot exam, wear, good shoes, make sure I see a lot of people that have poorly fitting shoes that have a ulcer from that. Good socks. I mean, it drives me nuts when I see patients come in and they're in flip-flops and their toes are exposed and they can't feel them. But yeah, you're still developing those bypass, the collaterals. It's just you don't really, you just can't necessarily sense it, but they're there. The biggest thing with peripheral neuropathy and diabetes is make sure you protect your feet. We've got to save those piggies.
Me too. And my final thought for you, Dr. John, that I'd love for you to comment on, because I think this is really important, is when it comes to the point where walking is not improving your symptoms over the course of a 3-month period, that's where you really, 6 to 8 weeks, you should see a little bit of improvement. By 3 months, you should start seeing a pretty significant improvement. And if you're not, and you're actually backtracking, or it remains to where this pain is lifestyle limiting, or it progresses to the point where you start having rest pain, those Charlie horses that wake you up at night, or hope to God that you don't have a wound that won't heal. But if you do, that's the time for a procedure. But I want to drive home the point. There are literally 2 reasons to have a procedure, right? It's the whole thing is to get you that much more blood flow to, number 1, heal the wound, and 2, give you a little bit of relief so that you can get out walking to grow your collateral network of vessels. Because it's not a matter of if these procedures are going to fail, whether it's an intervention or a bypass or an endarterectomy, even where they scrape out the plaque manually. It's a matter of when they're going to fail. And the whole key for these procedures is to get you immediate blood flow to trial to heal the wound, and to give you that much relief so you can get out and walk, and grow your own natural bypasses. So when your arteries do reblock, when your bypass does block, ultimately the goal is that you will have created enough collateral vessels that you won't need to keep this revolving door of procedures going. Am I right?
Yeah, I mean, so people that have peripheral arterial disease without a wound, meaning they don't have limb ischemia, there's a pretty well-defined treatment algorithm that we use. Reduce their risk, get them on certain medications to help reduce their risk, start the walking program, medication, psilocybin, Collateral, which can help improve walking distances, reassess. And like I've said this before, I'm the coach, you're the quarterback, we'll give you some plays, and here's the playbook. You can exercise, run pass option, so to speak. But I do tell patients, like, let's try the conservative method first. If this doesn't work, we can do an intervention. But typically, once you've had one intervention, you're going to have another one. If you have an ulcer or critical limb ischemia, that's a different ballgame. We've got to get you some better blood flow to help heal that wound, to prevent further tissue loss, to prevent minor amputation, to prevent major amputation. So 2 different buckets. But again, if you have a physician that you trust and they're thoughtful and that you can work with them, they'll help you along, and they should reassess things. If the walking's not helping, or the medicine, the Collateral or psilocybin is not helping, it's time to let's look at another play, and maybe that play includes an intervention or surgery.
But you got to be honest about it. You got to really give it that good old try. There are a lot of doctors, still, you and I talk about it all the time, that end up intervening too soon on what we call intermittent claudicants, the early stage patients, or the early stage of lifestyle limiting claudicants. And if that means when you walk, you start to feel a pain, when you rest, it gets better. We're not talking about advanced stage, which is defined by the wound that won't heal, the rest pain, those Charlie horses that wake you up at night. Like, that's a whole other ballgame. You need a procedure. It's these earlier stage, as long as it's not impacting your daily job and you're going to get fired, you need to really take into consideration, or at least take to heart, like, you need to make these changes and that they do make a difference. You don't want to jump in too soon for a procedure because, as Dr. John says, it's going to lead to another procedure. And we've had several patients who have come to us and have said, oh, my doctor's ready to intervene. And I'm like, well, you're able to walk 10 minutes without pain. Why are you going to go in and have a procedure when walking can make a really big difference, right? So don't be afraid to say to your doctor, hey, am I going to lose my leg tomorrow if I don't have a procedure? Can I try a regimented walking program? And they can go to PADhelp.org. They could sign up for our walking program and get a dashboard to monitor you at no cost. It's easy breezy. But really don't be afraid to stand up and say, hey, doc, I'd like to try walking in medicine first. And I'd like to try making those lifestyle changes that are critical. And I think that's so important, because if you don't stop smoking, if you aren't in a habit of walking, and if your diabetes isn't controlled, it's almost a moot point, right, Dr. John, to have these procedures, because they're just going to block up sooner rather than later. Your blood becomes, thick and sticky when you're smoking. It becomes thick and sticky when you have diabetes and your glucose isn't under control. And so I have so many patients that will come to me and say, I'm in so much pain. I need a procedure now. And I'm like, but you're still smoking. And your blood's just going to clot back up right away the moment you leave there, the moment you get off. I've been in a procedure where the patient was a smoker, and the doctor had just cleared out the arteries, closed them back up. And the moment they got him back out in recovery, blocked right back up again. Had to send him back in and redo the whole thing. And so it's really important to get those lifestyle changes under control before you actually go in and have these procedures.
Evidently, I was on Celestisol early on in my diagnosis, but I don't remember that at all. And my family doctor just recently put me back on it, like maybe a month ago. And in the beginning, I was like claudication free. Of course, I do walk a lot, but now it's kind of starting to creep back in. And I was wondering, can you up that dose or take it twice a day? Or is that harmful?
So the dose that has shown to be clinically effective is 100 milligrams twice a day.
Okay. So taking more isn't better.
No, 100 milligrams twice a day, because the rate limiting step for most people is GI upset, diarrhea. You can get some palpitations as well. I would say if you tolerate it, that's great, because it probably will help your symptoms.
Mm-hmm. And actually,
50% of people don't tolerate it.
What's interesting is nurse practitioner Deidre Arms, who's one of Dr. John's patients, heart patients, came on recently and said that ginger is a vasodilator, which is what Celestisol is. So if you want to add something to it, what is the harm of adding, some ginger capsules or additional ginger into your diet, right? Something to talk to your dietitian about. But yeah, I know that once she told me that, I boosted mine.
More ginger, the better.
More ginger, the better.
And not
Thanks
the
so much,
redheads.
John.
All right, guys.
Dr. John, final thoughts as we round about third here.
One word, exercise. Actually, 2 words, exercise. 3 words, exercise. Just exercise.
Great way to end it. Thank you so much, everyone, for joining us. We really appreciate you. If you want to find out more about our walking program through the Global P.A.D. Association, it's at no cost to you. It's at no cost to your physician's office. So go to PADhelp.org to find out more. Have a great weekend, everybody.
Take care, everybody.